Good afternoon, everybody. It's lovely to see all of you here today. A very warm welcome to you all. My name is Mark Bowie and I'm your facilitator as Deputy Director of the Centre for Palliative Care to our May webinar, Advanced Care Planning, Is It Worth Doing? As Deputy Director of the Centre for Palliative Care, we're involved in education and training. I'm also involved as the Director of St Vincent's Palliative Care Services. And this is an area of interest and that's close to my heart and the heart of many of our colleagues that work in palliative and end-of-life care. First, formally, I'd like to acknowledge country. I'd like to acknowledge the traditional owners of the land in which we meet today, the people of the Kulin Nations, where we're situated here in Melbourne, and welcome any Aboriginal or Torres Strait Islander people here present today in our webinar. I'd especially like to pay my respects to the Aboriginal elders, past, present. They hold the memories and traditions, culture and hopes of Aboriginal Australia. So welcome. It's exciting to introduce our speakers today. Our main guest speaker is Associate Professor Barbara Hayes. Many will know her, but for those who don't, she's the clinical lead for advanced care planning and a palliative care consultant at Northern Health since 2007, one of the major metro Melbourne hospitals. Barbara has a background in palliative medicine and she has a PhD in ethics. Our panel members contain Anne-Marie Fabry, Associate Director of Community Programs at Northern Health. We also have Sonia Gardner, who is the Officer of the Public Advocate in Victoria. Unfortunately, Linda Nolte, who is going to join us today, can no longer join us. And I'm sure we can all relate to this, that she's had some connectivity issues, which she was aware was going to be affecting her ability to join us today. You'll also see a list of bios from our other panel members on the website who'll be joining us today this afternoon. Questions are going to be held over right to the end of the broadcast this afternoon, and ask a question icon you should be able to see on your screen. And you'll be able to use this and ask questions at the end of the presentation. You can ask the questions earlier and then I'll be able to moderate them when the panel has finished their discussion. You can use any of the resources that are referred to by the light blue resource button located at the top of the screen. So that's an exciting possibility. So without further ado, I'd like to ask Barbara to speak and to take us through her presentation, and then we'll open up to the discussion with the panel. So welcome, Barbara.
Thank you, Mark, and welcome everyone this afternoon. Some of you will be familiar already with the recent debate in the literature about the worth of advanced care planning and the worth of funding advanced care planning programs. So it is very much a hot topic, an appropriate one for today's discussion. Before I start presenting though, I have some questions for the audience. And you're able to answer these questions. There are 3 questions. The first one, have you appointed a substitute medical decision maker? And throughout this presentation, I'll be trying to use generic terminology because I know as well as Victorian viewers, there are people from interstate and also some from overseas. So if you could answer that question, yes, no, have you appointed a substitute decision maker? Okay, I think we've stopped putting new answers in, so we might then move to our next question, which is, have you spoken with your substitute medical decision maker and family about what you would want them to know if they needed to make a medical decision for you, yes or no? Okay, we seem to have all those results in. Oh, we didn't. It just suddenly changed. just keep open just a moment longer. I think they've stopped answering. So we might close that poll and then move to the final question. Have you completed an advanced care directive, a written advanced care directive? Could answer yes or no to that. Okay, I think those results are all in. I'm going to come back to those results, but are you able to show those results on screen if they haven't already been shown?
Yep, all results have been shown now.
They've been shown. Lovely. Excellent. So I'm going to come back to those a little bit later. Let's look at the presentation slides. So this editorial was published in the Journal of Palliative Medicine back in 2020 by Professor Sean Morrison, who's a palliative care physician in the United States. And he made this comment: given the evidence gaps in our field, is it fair to patients and families to continue to focus our limited research workforce, finite effort, journal space, and scarce research and clinical operational dollars on advanced care planning while ignoring other needs? Isn't it time to finally acknowledge that advanced care directives / care planning is an answer that is clear, simple, and wrong? He also went on to publish a literature review with Diane Meyer and Robert Arnold last year, and they did a literature review looking at the outcomes of advanced care planning. And this is a comment from that article: despite the intrinsic logic of advanced care planning, the evidence suggests it does not have the desired effect. Many clinicians may be disappointed that promoting conversations with patients well in advance of needed medical decisions has not improved subsequent care as hoped. So these are some of the problems that were identified within the advanced care with advanced care planning in the articles. Difficult to anticipate future health situations, difficult to anticipate how one might adapt to a changing health. No evidence that it improves goal concordant end-of-life care. That's a bit of a worry, given that that's really the main aim of advanced care planning. No evidence that it improves quality of end-of-life care. Advanced care directives are not always available or adhered to. An advanced care directive can prompt avoidance of further treatment goals discussion. Advanced care directives may be too prescriptive or too vague to be of use, and a person's own preferences may be limited by the needs of others. So some of these points are inherent limitations of advanced care planning. Some are system issues unrelated to the person doing advanced care planning, and point to a need for better education and for clinicians to do better in their part of identifying advanced care planning documents and advanced care planning and actually utilising them. And certainly the last point recognises that people's autonomy is often limited by the autonomous needs of other people. So do we throw in the towel and give up on advanced care planning initiatives? What I want you to do for a moment is suspend reality and consider what it would look like if we banned people from talking about their preferences for future treatment. They're not allowed to talk to their family, their substitute medical decision maker. They're not allowed to talk to their doctors and clinicians about what they would want at a time when they can't speak for themselves. This would actually mean that many medical treatment decisions that are made for a person once they've lost capacity would be based on paternalism from the clinicians and from their family. So that, to me, that doesn't seem very desirable either professionally and sort of as a person who might one day be in such a position. I'm not keen that I quite like that idea either. I think it's important to remember that people have been doing advanced care planning for a very long time, long before it ever became a thing. And advanced care planning has put structure around that with education, forms, processes, systems to capture advanced care planning documents, and so they're available when needed. And there are some people who do advanced care planning very well and for whom it works very well. And one example is people of Jehovah's Witness faith who may wish to refuse certain blood products. They are very good advanced care planners. They complete advanced care directives. They appoint substitute medical decision makers. Moreover, clinicians are used to following those instructions. So it works well for this group of people. So can it work well for others? Maybe the important question is to ask how we should support advanced care planning and facilitate this, particularly for people who are not aware of their rights to do this. And for me, it would be a particular injustice to leave it to just luck for people to discover they can do advanced care planning, that, and this would really unfairly benefit people who speak and read English, who are highly IT literate, and health professionals. And so other people would actually be unfairly get an unfair outcome from just leaving it to chance. It is also not a just resources of our resources, just use of our resources if we provide them to people who actually don't want them, when there are other people who actually do want them and can't access them. So I think there's some good ethical reasons why we should be considering advanced care planning and maintaining it. This is an article by Rebecca Sadore and Ryan McMahon, who also did a literature review in 2021, and they tried to restrict their literature review to those articles they identified were very high quality research. And this is what they concluded. Although some data on quality of care outcomes, such as goal concordance and health status outcomes, such as quality of life, were mixed, increased patient and surrogate satisfaction with communication and medical care and decreased surrogate and clinician distress were consistently positive and maybe more appropriate advanced care planning outcomes. So I think what this article is identifying is that outcomes related to advanced care planning are patchy, and how can we make them more consistent? But they also identified that there's a very important part of advanced care planning that's about relationships, about patient and substitute medical decision maker satisfaction with quality of care, and also reduce substitute decision maker and clinician distress. So perhaps we're not always focusing on the best measures of advanced care planning outcomes, and these authors would suggest not. So how do I think we should conceptualise advanced care planning? I think consent is at the core of advanced care planning. And I think we fail with advanced care planning when we don't integrate the two. Advanced care planning makes no sense if there is no understanding of informed consent. So once the person loses the ability to make their own medical treatment decisions, advanced care planning and consent are inseparably intertwined, because advanced care planning is about consent to medical treatment on behalf of the person who lacks capacity to make their own medical decisions. And it draws on principles of respect for autonomy, a right to be self-determining, and there are also human rights principles. So the right not to be treated in a way that you wouldn't wish to be treated just because you're not in a position to advocate and speak for yourself. So what is it? I think we get into all sorts of difficulties when we lose that focus on consent. And I think this is my list. This is my list of what I think advanced care planning is not. I don't believe it's a tool to stop people going to hospital. It's not a way to prevent patients receiving futile or non-beneficial treatment. That's our job as clinicians. We should not be offering that. Having a written document should not be essential to avoid treatment that everyone knows you wouldn't want. It's not a medical treatment plan in advance of deterioration. It should not be compulsory for any group of people. You cannot say it's based on autonomy and it's compulsory. Those two statements are incompatible. It is not a way to reduce health expenditure. And in fact, some people do advanced care planning to actually ensure they get enough care. They're frightened they won't get as much care as they want, nor is it done primarily for the benefit of a health service or organisation. It is about the patient, the person who's doing the advanced care planning primarily. So I think it's important we don't throw the advanced care planning baby out with the bathwater. And so having looked at some of the debate about advanced care planning, let us look at some of the process. So advanced care planning is planning done by a person with capacity for a time when they might lose medical decision-making capacity. I'm actually a purist in this. I believe you do it when you have capacity. When someone loses capacity, we are not doing advanced care planning. What we are doing is capturing in writing prior communication that is advanced care planning. So it's a way for that person to have a voice in any medical decisions about who will decide for them and how will they decide. They may provide instructions for consent or refusal of specific treatment, and it's a way for them to support and help their substitute medical decision maker when making decisions. So coming back to Rebecca Sidori and another article by her and Terry Freed. This was published way back in 2010, and they said that the main objective of advanced care planning, rather than advanced treatment decisions, should be to prepare patients and surrogates to work with their clinicians to make the best possible in the moment medical decisions. So what they're saying is we shouldn't be having a menu of treatments people do and don't want in the future should they get sick from some unknown or known condition. But and it may be that there are some very clear instructions they can give and say there are certain things I will never want, and I'm going to make that clear. But oftentimes we don't know enough about what might happen to us. Maybe I'll get a stroke. What side of the brain is the stroke? Will I lose my speech? How will it affect me? So oftentimes it's easy, when the deterioration happens, there's a lot more information available about the illness, the prognosis, the treatment options, and the risks and benefits of those. And that's when the substitute decision maker can then start to weigh it up on behalf of the person. But they need to know what they need to know to make those decisions, to represent the person and what is important to them. Some people might, I keep saying patients because I'm hospital-based, but some people may actually tell their medical treatment decision maker, their substitute medical decision maker, you decide. Whatever you decide is fine. And that's okay. But oftentimes people will drop little bits of information along the way to guide the person. I think there's also another aspect to this, and that is when someone does advanced care planning, it also encourages them to start thinking themselves about what is important to them, how they would want decisions to be made, what would be outcomes that they would really want to, just would be absolutely horrendous to have to live with. So it allows them to start processing this ahead of any significant deterioration. So it can be really useful if they become unwell and have to make their own decisions because they still retain capacity. So many of you will be familiar with our approach at Northern Health to advanced care planning because it's been picked up by a lot of other health services across Victoria. We based this at the time we developed it on the literature and also on some research that we did with hospital interpreters because we wanted to better understand how advanced care planning might affect people from different cultural groups, different faith groups, and we didn't want to harm people by talking about advanced care planning. And we came up with advanced care planning in 3 steps, and we used the mnemonic ACP, A, appoint another, which is the substitute medical decision maker, or in Victoria, the medical treatment decision maker. C, chat and communicate. These are the conversations that happen over time where, the dinner table or when you hear about somebody who's become unwell that and you start to craft some thinking about what would be important to you, what you might want to avoid. And then some people will go ahead and put it on paper as in an advanced care directive. So The authority of the substitute medical decision maker is to represent the person who lacks capacity, and it is to make the same decisions as near as possible to what the person would want. So they should consent to treatment the person would consent to, and refuse treatment the person would refuse. So can I say to you, please don't ask the substitute medical decision maker, what do you want us to do? The better question is, what do you think your mum would want in this situation, or what do you think your dad would want? And remember, the substitute medical decision maker is not the clinician's substitute. We have to take responsibility for our part of the decision making. Many people will already have a suitable, non-appointed substitute decision maker, and that how those people are identified will depend on the jurisdiction in which you live. So many people will be quite content with who their default decision maker is, but if you are not, or if your patient is not, then they should be encouraged to appoint someone they would want to be the decision maker. We should also be encouraging people when there is likely to be confusion about who the substitute medical decision maker is. A third group, and I left this off accidentally, is people who will not have a default substitute medical decision maker. So there will be nobody to make decisions for them if they lose capacity. And so it's an opportunity to actually identify someone who might be a decision maker, be it a more distant relative or a friend. We had someone who appointed their parish priest, who is someone who they trusted to make decisions very consistent with what their own beliefs were. So in our audience today, we had 33% had appointed a substitute medical decision maker and the rest had not. So I'm assuming those who haven't will be happy with their default decision maker. But if you are not, then you need to appoint somebody. So what is the authority of the Advanced Care Directive? So I think it's really important to understand that there are different types of Advanced Care Directives with different types of statements. So some statements actually will give binding consent or refusal to treatment. And in Victoria, we have an instructional directive that does that. So the substitute medical decision maker cannot override that. It is between the person themselves who wrote the Advanced Care Directive, the instructional directive, and their clinicians, and the clinicians must follow that. There are other types of statements are value statements. They are there to say, well, these are the important things that I want considered when decisions are made. And they are primarily to guide their substitute medical decision maker. But of course, as clinicians, it's really useful for us to know what is in those documents, because then we can help the substitute medical decision maker to use that information, and we can advocate for the person themselves. So I think it's really important not to ask, is this a legally binding document? All written and oral communication has legal weight, and we need to apply it according to the legislation in our own jurisdiction. So this is an area where you do have to understand the legislation around this. Understanding the difference between binding consent and aimed at the clinicians and value statements aimed at the substitute medical decision maker are really important. Anyone can initiate discussions about advanced care planning and directives, but each jurisdiction will have its own laws about who can witness documents in order for them to be valid. And doctors need to be one of the witnesses in the state of Victoria. So we need to encourage advanced care directives for people with very strong views. These are the people who front up and, where do I sign? People who will have no substitute medical decision maker. So, and I think Sonia will talk more about this later on, but the Advanced Care Directive is their voice to tell people what is important. It's also important that we encourage it where people have different views in the family. We know everyone will know exactly what mum wants, except everyone will have a different view about that. And people with disability, that was a group that was given to us by the Office of the Public Advocate. And the reason being, oftentimes people with disability can actually make their own decisions if given the right support, having a support person and given information in the correct way. So putting that in an advanced care directive is really useful. So our audience poll showed that only 18% of our audience had completed an advanced care directive, but 53% had actually spoken to their substitute decision maker about what is important. So our patients, the people we care for, are not so different to us. Many people won't write an advanced care directive, but they may have communicated lots of information verbally. And I think it's really important that clinicians help the substitute medical decision maker understand what they actually know already about the person's preferences and values. So not just asking would they want this treatment, but asking about how their health is going, what is important to them, what are they fearful of in the with regards to their health, so that we can help them understand how to apply that information to the decision at hand. In Victoria, we have some resources for people who lack capacity to complete an advanced care directive, and this is a form called What I Understand to be the Person's Preferences and Values. It is not an advanced care planning document, but it is a way for the substitute medical decision maker and other people who know the person to actually record away from any crisis what they actually know about this person's prior instructions, preferences and values regarding their health. So there's a link to that there. I just want to mention the goals of care form. This is a medical treatment order. It is not an advanced care planning document, but may include some advanced care planning information. It describes a medical treatment plan that takes account of the person's medical illness and the limits, if any, to what is medically feasible, and the person's preferences and values related to medical treatment within those limits. And that is where advanced care directives and advanced care planning come in if the person has lost their capacity to make their own decisions. So this is a shared decision-making process involved in goals of care, and there's a link to the residential aged care version of the goals of care in the resources. I just mentioned a couple of other resources that I think are really useful to look at for those of you who are in Victoria. There's some guides for medical treatment decision makers and clinicians about medical decision making. And there is this brilliant flow chart called Can Your Adult Patient Consent? And the Office of the Public Advocate now has an app that you can download so you can carry consent in your pocket. So, my final slide. Advanced care planning, is it worth doing? I believe it is. I believe advanced care planning is worth doing if we believe informed consent is important. But I think it is worth doing well. And I think it's really important that we don't expect more of advanced care planning than it is designed to do. So, and it's not everyone will do advanced care planning. For some people, it's a place too hard to go. Some people will do advanced care planning for the benefit of their children rather than because they see a need to do it for themselves. A common reason is having had to make really difficult decisions for a family member and feeling they weren't prepared enough, so they want their children to not be in that situation. But it can never be compulsory or coerced if it's going to be based in autonomy. And so I'll hand back to Mark now. Thank you.
Thank you, Barbara. That was terrific presentation, and thank you for putting a lot of clarity into the concept, but also the reality and practical reality of advanced care planning and that shift to focus on advanced care directives as well as the role, responsibilities of those medical treatment decision makers. Now I'd like to welcome Sonia and Anne-Marie to join Barbara in the afternoon platform. And it'll be good to then now ask some questions of them. I might lead with a couple of questions and then we'll certainly go to the questions that are coming into the presentation box for me to have a look at in a minute, so thank you. Sonia, the first question I'm going to direct to yourself, and Barbara's already mentioned that in your role as the Victorian Office of the Public Advocate, you need to make decisions at times for a person who lacks medical decision-making capacity, and proposed treatment, particularly when the proposed treatment is significant. I wondered if you could just comment on how does ACP help you, or what do you need to know when you need to make those sort of decisions on behalf of somebody, and also maybe just to comment on what is significant treatment.
Sure. Thanks, Mark. So yes, I work at the Victorian Office of the Public Advocate. But firstly, I'd like to point out that in relation to that question, Mark, anything that I respond to relates to whether it's our office acting as a medical treatment decision maker or as a guardian, or for anyone in our Victorian community who finds themselves in the role as guardian or medical treatment decision maker, be that appointed or as a default. So when matters come to our office to have to act as a substitute medical treatment decision maker, our legislation gives us guidance on how those decisions are to be made. So under Section 61 of the Act, it tells us that we firstly have to consider if the patient has made a values directive. So you will have heard Barbara talk within the Advanced Care Directive, there are two components, either an instructional directive and or a values directive. So if we're asked to make a medical decision for someone, we first have to consider if they've made a values directive and take into account that information to then make a decision. Otherwise, the law is asking us to make a decision based on the patient's preferences and values. So that's what the patient can tell us now, whether they have capacity or not. They can still express at times what they may or may not want in regards to that treatment. And it's having to talk to other people who may know the patient, so their GP, friends, there may be case managers, support coordinators, to get a sense of what's been important to that patient, because the Victorian legislation requires that we try and make that decision the patient would have made if they had decision-making capacity. Only if that can't be ascertained does the law allow us to then make a decision in the patient's for their personal and social well-being. So you mentioned also around significant treatment. Now, in terms of that terminology, which is a legal definition in the Act, that actually only becomes relevant for doctors or health practitioners to consider if there is no other medical treatment decision maker. So if there's a patient who doesn't have anyone appointed, hasn't made an advanced care directive, and there's no other family member who would meet the hierarchy, then the doctor has to think if the treatment is routine treatment or significant treatment. If it's routine treatment, our law says the doctor can proceed to provide that treatment without consent, pending some documentation. If it's significant treatment, that's because the doctor has determined that that treatment has a significant degree of bodily intrusion, significant risks, significant side effects, or significant distress to the patient. And that's when it will come to our office under my team. Last point, however, it was a guardian coming to our office. They may still have to make the routine decisions as well as significant. So I wouldn't get too caught up on the idea of is it routine or significant treatment. It's more of a starting point of a person's decision-making capacity, and then whether there's a person to follow that process of making a decision based on the patient's preferences and values.
Great. Thank you, Sonia. Look, Barbara's also mentioned in her presentation there's a lot of resources that the Victorian Office, and I'm sure other jurisdictions around Australia in a similar capacity, provide in terms of advice and education. Is this something that you're particularly involved in, or spend a lot of time in that education space?
Yeah, so Mark, our office, and I would assume it's comparable throughout the country, but I can't guarantee it. So we have our website, which has been referred to with a number of resources, but we also do what we call community education. So that's some scheduled presentations we do on advanced care directives, on advanced care planning, medical treatment. We also have the option for requests to be made to the office, and we can do targeted presentations out to the community. So we have quite a significant role in that education and advice space.
Great. And Anne-Marie, I might just bring you in here, but where else can people go to then to get that sort of education, read up on resources and so forth around advanced care planning?
Thanks, Mark. And there is a lot of information out there freely available now, which is great. In addition to the Office of the Public Advocate in Victoria and the equivalents elsewhere, I would probably recommend as a starting point Advanced Care Planning Australia's website. So that's a nationally based website, so it has links directly to state-related laws or other state-specific information. In addition, on the Advanced Care Planning Australia website, there's free online learning resources and links to other face-to-face, pre-COVID face-to-face education sessions. So I think that would be a useful place to go. In addition to that, and I can speak from a Victorian perspective, many of the health services that offer advanced care planning programs have a lot of information on their websites as well, some of which is obviously areas specific to Victoria or their local area, but some of it is also relevant nationally. So I think in your resources you've got access to the Northern Health website, which has a lot of information, some of which Barbara referenced during her talk. But as I said, if you don't have a local site, I would definitely go to the Advanced Care Planning Australia website as a starting point.
Okay, thank you. I mean, often we talk about advanced care planning in the broad context at many stages in people's illnesses, but often it's left until there's a sense that end of life is approaching. And I'm just wondering, we often hear where doctors say to somebody they're not ready for ACP, they're not facing their end of life. What are your sort of thoughts around this, around the timing of kind of advanced care planning discussions?
Well, in my experience and my opinion, I think the right time for an advanced care planning discussion is when the patient or the person themselves is ready for it. And our job as healthcare providers is to kind of be observant to when that time is. So I think we need to be aware of what's going on with that patient, person at the time. If there's the suitable time might be when there's a change in circumstances. For example, it might be a new illness, or it might be a deterioration in that illness, or it might be even an injury, or it might be something to do with another member of their family, somebody else has had a stroke or a terrible car accident or something, and it's an opportunity for the individual to start to think, gosh, what if that happened to me? I wouldn't want to end up like that. So if we're hearing those sorts of conversations, that's perhaps an opportunity to introduce advanced care planning. It might actually be a circumstance of a happy event, like perhaps retirement. People are thinking, well, this is a new phase of my life. And often when people are starting to, get their affairs in order, they might think, well, now I need to think about my finances into the future. This is an opportunity to think about their healthcare and decisions around that time for the future. I think it's important to kind of remember that there's no such thing, I think, as one advanced care planning discussion. Most people have many discussions over an extended period of time and with a number of different health professionals. So I always kind of think that even a little conversation that you might have, it might be just sort of saying, look, this is not the time perhaps for a long conversation, but here's a brochure about advanced care planning, or somewhere you can get a bit more information, or just little snippets of the conversation over a period of time. Gives people time to perhaps digest that information and how it might be relevant for them. For example, I might think today, well, it's important for me to appoint a medical treatment decision maker, but I'm not going to write stuff down at the moment because really, I'm well and fit and able. Maybe I'm not really ready to think about that in more detail, but I've kind of made sure that my person knows that I've nominated them and that's my decision maker if it needed to happen. I think when we talk about individuals not being ready for advanced care planning discussions, I think we sometimes need to turn the spotlight around to ourselves as health professionals, and I think it's often us that are not ready for an advanced care planning discussion. We're worried about upsetting people. We're worried that people will think that their circumstances are maybe worse than they really are, or maybe they are not very good circumstance and we're worried about bringing that up. But certainly in my experience doing advanced care planning for many years and also presenting in the community, doing education sessions around advanced care planning, so often people said to me, why have I never heard about this before? Why has my doctor never mentioned this? Or I've been going into the hospital for appointments for years. Why has nobody ever told me about this? So there really is an expectation from the community that we will bring it up. You know, so I think that sometimes we need to just be mindful of our own limitations and concerns. It's certainly something that gets easier with practice.
Yeah.
But there's not ever an expectation that one person, one nurse or doctor or other healthcare worker will have the whole conversation. You know, one individual doesn't need to know all the answers. Lots of times people would say to me, oh, what about this? Will I have that treatment or is this going to happen to me? And I would always be like, well, I'm not your treating doctor, so I don't know those details, but let's make a list for next time you see your doctor and you can ask those questions then. So I think every bit of the conversation is worthwhile, and there is a bit of a cumulative effect. But as I said, I think in terms of timing, a lot of the onus rests with us as the healthcare workers, and that's our part of our remit to pick up and run with.
Thank you, Anne-Marie. Look, and just picking up the point for Barbara that, as you said, it can be several conversations. As you know, you've already mentioned it might be one conversation, it gets left and it's sort of in a dusty drawer somewhere. But I'm just wondering the practical way of tackling things, Barbara, if you do have an AC, an advanced care directive that seems sort of out of context or can't really be understood in the current context of a person's medical issues and problems.
Thanks, Mark. I think sometimes, advanced care directives can perhaps not be clear in terms of how to apply it to the current situation. Sometimes they seem to have conflicting statements in, and I think it's really important to use what you've got written down as the basis of a discussion with the medical treatment decision maker, the substitute decision maker, and say, you know, I see your person has said this. Can you tell me a little bit more about what they were worried about? Have they spoken to you about this? So I think you can't, if an instructional directive is unclear and you can't act on it, it becomes a value statement. So you have to then consult with the substitute medical decision maker about that. But I think use whatever is written down as the start of the next conversation with the substitute medical decision maker, and between you sort of nut out what was intended, or maybe they just hadn't even considered the current situation and it doesn't really apply, and so we actually need to start a bit from scratch. But some of the things that they spoke about relating to another decision may very well help us understand this current situation. So I think, always take these things as the start of the next conversation.
Great. Thank you. Look, we've had a lot of questions coming in just in the last few minutes, so I think that's a nice segue for the panel to the first question I'd like to ask, and it's really asking, what is your advice? And maybe I could direct this back to Barbara. When working with someone who's had a lifelong, say, cognitive impairment, when the person's never really been able to communicate wishes or values, how do people approach that situation?
Okay. I think as Sonia mentioned before, decisions need to be made that promote the person's social and personal well-being. That's what you're aiming to do. And even though they cannot articulate verbally what is important to them, there may be things that are really helpful to understand. So how do they cope with going to hospital? How do they cope with having IVs put in? How do they cope with having blood taken? How do they cope with the change of environment? So these are non-verbal things, but they help us to understand how a treatment options might be received by that person, how distressing they might be or not. And I think it's really important to talk to the people who've known them over time, who are really good at understanding these things and reading the person, but using whatever you have and what you can. I think it's important that we don't withhold treatment from someone with a disability just purely because they have a disability. That would be a discrimination. But what we need to do is look at how they're likely to respond to various types of treatment and whether that may distress them beyond what might be acceptable. There are quite a few people in that, who are like that. And there are also people who had capacity, who've lost capacity, but over time their responses change. So a person, say, with dementia, who was really happy to go to hospital, really happy to go in the ambulance, really happy to have IVs put in, is now terrified. That's going to change how we think about what is going to be right for them, even if they haven't told us anything verbally or written anything down in advance care directive.
And it's most probably very difficult to understand and moderate when those more critical moments arise and who can actually walk people through it. I just wondered if Sonia or Anne-Marie had any other comments on that particular question.
I do, because this is quite a common space that the office we find ourselves in because we work with people with disability. Just adding to Barbara in terms of trying to give some concrete examples. So it may be that the proposed medical treatment is relating to fixing a broken hip or a broken leg. The patient may be someone who's had a lifelong cognitive disability, may even be non-verbal. But when we speak to the house supervisor, we hear that this is a patient who really likes to walk and walks every day. That forms a big part of their routine. It seems to be something that they enjoy. So we could infer from that the patient really values being mobile and being independent with their mobility. So therefore, having medical treatment would support that value that we were inferring from their lives. Similar if it's around cataract surgery. And we hear that the person is someone who really enjoys watching TV or looking at pictures. And so again, that's informing a value for us to make a decision upon. So it's taking into account those non-verbal cues of what the impressions are of people who know them, of what seems to be important and what's of value in their life. What is a more complex answer to give? We probably don't have time. But again, is what Barbara was starting to allude to, is what happens when people can express preferences. So they may have written something down, but now they're saying something different. They may have expressed one preference to one person, but a different preference to someone else. So that kind of complexity takes a little bit more time to work through, but we have to realise that we're not static people, and like anyone, we can all change our minds at different times.
Great. Thank you. Look, it's interesting. A couple of people have sort of commented on ways in which maybe to advance care planning, and one in particular has used the example, I'm sure in other places around the world, that having these discussions, sort of life skill training for younger adults, people coming through high school, coming into their senior years, and it's certainly highlighted in this particular scenario of sons going into the Defence Force and doing their wills at 18, but also, the whole notion of people understanding these things as life skills at schools. I just wondered, maybe Anne-Marie, about education and the work of education for our younger adults or teenagers who are finishing high school and so forth.
I think that's a hard one. I think that preparing a will when there's a possibility of death, which is possible for all of us, is a bit more black and white, are either alive or dead. I think there's a lot of difference between the way that a 18 or a 20-year-old might think about what if I have a stroke, and maybe a 60 or a 70-year-old, what if I have a stroke? I think as we get older, our life experience and expectations is different, and we know that, you know, as we get older anyway, we learn to deal sometimes with disability or illness better than we imagined that we would have. So I think it's an important thing for at any age for people to be starting to think about if life was different or what is important to me. I just think that if we start very young, we need to make sure that we encourage those same people to continue to update their conversations and their documents if they write something down. Because as we've we've discussed earlier, having a very out-of-date written document is very hard to unpack, and particularly in the midst of an emergency or a bit of a catastrophic situation. So, but I think if we were to normalise conversations around death and dying and disability in general from an earlier age, perhaps we'd be better placed as older adults to be starting to have these conversations and writing things down for other people to use when a decision needs to be made.
Thank you. And one of the other people watching the webinars asked the question, as I guess is becoming more common nowadays, would litigation be a driver for clinicians and organisations to adhere to ACDs, to advanced care directives? And is in fact litigation something that we hear of in this space? Maybe Sonia might...
I can try and answer. Essentially, that's not something that would necessarily come directly to our attention, but a couple of things to maybe make people aware of, at least in Victoria. So where there's contention around an advanced care directive or interpreting that, our Victorian Civil and Administrative Tribunal is the arbitrator to take a matter to. So it doesn't have to rely upon the health practitioner interpreting that advanced care directive if there is something that's quite contentious. Taking that matter to VCAT, they would look to address that. But I think the issue of kind of litigation, the concept of negligence, certainly comes up for doctors and just any medical treatment day-to-day decisions. And I think it's helpful for health practitioners to have some understanding, again, in Victoria, of the Medical Treatment Planning Decisions Act, which talks about where the protections are around ensuring that treatment hasn't been negligible. Barbara talked before about futile and non-beneficial treatment. That's Section 8 in the Act. It talks about doctors not being compelled to offer treatment that they're deemed to be futile and non-beneficial. So I think it's sometimes about knowing the law to then know how that protects doctors if they're concerned about that litigation. But in terms of advanced care directives has also only been possible in Victoria since 2018. It's maybe too soon to kind of seen anything be litigated any further than that VCAT space. And VCAT isn't necessarily going to hear that matter similar to a county court, for example, but it is there to assist with those issues and advice around advanced care directives themselves. Just as a last point, I also wanted to make clear, and I know Barbara again talked about it, when we're talking about advanced care directives, there are the two components. So sometimes it may be an instructional directive, which is that binding instructions upon the health practitioner, but there is also the values directive. So it's important to kind of know that advanced care directive may hold both or just one of those, to not get too caught up that these documents become absolute.
Thank you. Look, we've had a few comments on resources. Somebody's asking if you could, Barbara, maybe name the app that was and what it was called for advanced care planning again. And then there's a couple of questions, just seeing if we could be directed, people could be directed in the chat room to the resources around literature about the academics arguing against ACP, and also the literature that distinguished between goals of care and an advanced care plan. So.
Okay, the app is available from iTunes and Google Play, and I think it's search on patient consent, but it's the title of the app is Can Your Adult Patient Consent? It's basically talks about the legislation related to consent. The difference, off the top of my head, I don't have, I can't tell you of any, actually the one resource that I can think of off the top of my head is if you go into the Office of the Public Advocate website, Victoria, and look at a clinician's guide to medical decision making, that will describe the differences between advanced care planning and goals of care. There are publications with published articles about what goals of care forms are, and I can probably make those available, but I just can't recall. I don't have those references off the top of my head. Sorry. And we've also done some research looking at the relative effect of advanced care planning and goals of care in residential aged care on acute hospital use. What was the other question?
And maybe you could put it in their chat for the audience, maybe, if possible. It's just knowing the resources that you quoted at the beginning of Sean Morrison, those papers in the papers that discuss advanced care planning.
So I had the references to those articles on the screen. So if you look at the slides, you should be able to see those.
Yeah, great. Look, we're coming up towards the last couple of minutes, but I've got an important question here, and somebody's raised the whole issue of moral distress, and it's moral distress for staff and sometimes families that are, there's a discordant, I guess, advanced care directive, and on one hand, you've got a frail elderly person that is moving towards the end of life, but the documentation indicates full resuscitation. And they're just commenting on the difficulties of medical people taking leads in this situation to look at fertility and all those sorts of issues. But the fallout, I guess, is that it's a transfer and a resuscitative process for frail elderly that's causing quite a bit of moral distress and putting a lot of pressure on people within residential aged care. It's a complex issue, I know, but I just wondered in the last couple of minutes if anyone can just make some comments on that particular concern.
I can at least start. I think there's a couple of things that I'd point out. Again, it's not confusing what an advanced care directive is and what is an advanced care plan. The advanced care directive has legal connotations with its witnessing and eligibility. But I think of the example that's been given in the question is also needing to consider what treatment is or isn't being offered by the doctor. So a person may have written, in whatever format, I want full resuscitation. However, if my condition is then such that a doctor doesn't offer me full resuscitation, the doctor can't be compelled to do that. So just because something is written down doesn't make it so. And then maybe I heard in the question around some concern about doctors taking the lead. The Medical Treatment Planning Decisions Act in Victoria, again, we'll talk about futile and non-beneficial treatment, but there's also an expectation within the Act that a doctor, if making such a decision, can be asked for a second medical opinion, but should be still liaising with the family, friends, or other significant people in the patient's life about decisions like NFR orders or CPR orders. Right. So it's a little bit more layered than just it being a black and white, do everything the doctor says or do everything.
Thank you. Look, maybe that was a tricky question to end on, but really we are coming up to the end of the hour, and unfortunately we're just going to have to cut the discussion short. It's been a robust and good discussion and a lot of good information. I'd really like to thank Barbara, Sonia and Anne-Marie for the presentation today and also the discussion. The video from this presentation will be available soon on our website, hopefully later this week or if not into next week. And we look forward to having you all again at the next event. So very appreciative of your time and your participation, and very appreciative of our colleagues who've spent time, Barbara, Anne-Marie and Sonia. So thank you. We'll see you next time at our next hot topic.